time. The pandemic is not over. We heard we passed the 1 million deaths this year milestone, and there are about 14,000 deaths per week stabilized now for many weeks. So my name is Ann Lindstrand. I work with the COVID Delivery Partnership as Deputy Director to Ted Scheiben that we heard before, and also head of the EPI unit in WHO in Geneva. And as such, I will be presenting a lot on the global update of the latest data that WHO is collecting. Next slide. Together with a lot of partners, we collide and get a lot of data. And thanks to all of you, member states, that is possible. So you will hear, you've heard from all the distinguished speakers this morning, some figures here and there, but here you will get it all in one package, a lot of a deep dive on data. I will speak on both the COVID vaccination, routine immunization, and integration. So a staggering 12.6 billion doses have been delivered across the world. Still, with vaccine inequities, 63% of the global population fully vaccinated, 18% in low-income countries, and only 13% coverage of the primary series in countries where they are struggling also with humanitarian emergencies. Having said that, there has been, by many of you, extraordinary efforts, particularly in the last couple of months, and increases in coverages. Next slide. You can take the next slide. Yes, here is also like a summary key numbers that I will be going through. 12.6 billion doses, as I said, administered globally, 63% primary series and 18% in low-income countries. There are only 62 countries of the 194 member states of WHO that have reached 70% so far. 131 reached 40% and 182 have reached 10%. So and beyond. And also 178 countries are now actually having a policy on booster doses and starting to roll out those projects. COVAX has so far supplied or delivered 1.62 billion of those. 12.56 administered so far. So I think about 13% of the global administered doses so far. And as Sept was saying, 80% in low-income countries. Next slide. Now, here you see on the left-hand side, all the WHO regions and the coverage of 2 doses primary series in the dark blue. And on the right-hand side, it's the income groups and also the AMC, non-AMC, so which is the advanced market commitment, the COVAX supports. You can see that Wipro is far ahead. 84% have been reached with the primary series. And then the other continents are Europe, AMRO, CRO, about 70, almost reaching 70. Many of the speakers previously have mentioned the painful facts that only 21% of the Afro region population has been reached by 2 doses and 23% in AU continent and low-income country at 18%. Next slide. So here you have 3 buckets. Those member states of WHO that have reached more than 10%, more than 40%, and more than 70%. On the right-hand side, you can see that many of the other regions are struggling to reach the very high target of 70%. So it's actually only in Euro 18 countries that have reached beyond the 70%. In Wipro, many more. And in Afro, you have 3 countries that have so far succeeded in this very ambitious goal. Next slide. The fantastic piece of these vaccines is the safety they offer, but also the effectiveness. But particularly the effectiveness, if we want to have a high impact on the pandemic, these vaccines have proven to be very effective against severe disease and death, in particular in the highest risk populations, the healthcare workers, the elderly. And here you have data from about 140 reporting countries on healthcare workers and the elderly. And as you can see, the first lot is WHO regions, and on the right-hand side, income groups. Member states have on average vaccinated 75% of their healthcare workers and 77% of the elderly populations as of August 29. And this represents 79% of the global population. Here again, you can see that the Afro region is lagging behind. 48% of the reporting member states have reached the 48% of the healthcare workers have been reached in those 138 reporting countries, and for the elderly in Afro is 34%. So there is still a huge work to be done, and particularly with the new vaccine strategy that I will be presenting, this is what is being emphasized. Next slide. So there was a need for a new vaccine strategy. Before, we had a very singular view on 70% coverage, and that was what we needed to do as an aspirational kick for really making vaccination high on the order. Now, the WHO and partners were really discussing hard how to tweak and look at it when we learned more and more about these vaccines. Very good to stop and hinder or being effective against death and severe disease, less so on disease transmission, which, as we know, have given us rounds and rounds of new epidemics of peaks of COVID cases and deaths. But the new thing in this vaccine strategy is that it highlights the progress that already has been made towards the goal. It focuses particularly, and number two is the most important, focuses on protecting 100% of the healthcare workers and 100% of the older adults and those of highest priority groups on the way to the 70% target of the full population. So this is upfront, and it's part of the M&E that we are building as well. I think this is very aspirational, of course, but it is an intent in this global strategy of really reaching those that need these vaccines the most. And it's not only with the primary series, it includes also the booster doses. So I'll come back to that. It emphasizes also the delivery approaches that is needed, that we need to build in throughout the life course. And finally, the strategy looks more on innovation and the new vaccines that the world are needing to be able to stop transmission, for example, or have more durable protection of the vaccines that we have. So promote the distribution and access and manufacturing of new vaccines, and then innovation to get us the vaccines that have these higher effect on transmission and can help us end the pandemic. Next slide. The vaccine strategy framework has two goals on the top. The first one pertains to the vaccine and the vaccine rollout. And it really is about sustaining and enhancing the momentum to reduce mortality and morbidity, protect health systems, and resume socioeconomic activity. And it goes stepwise. So the highest priority first, including the booster doses, and then you go stepwise. And not until those are covered, the highest risk with both booster doses, then you go down into pediatric, for example, vaccination. And then finally, to accelerate the development manufacturing of vaccines that have a durable, broadly protective immunity and that can reduce transmission. Next slide. Are we succeeding then? This is a pretty complex but very visual depiction of where we are at the moment and what countries are prioritizing, right? These are like 70 reporting AMC countries. And on the x-axis, you have the percentage total population. And on the y-axis, it's the percentage in healthcare workers. So if we would have seen all countries make priority for healthcare workers, they would all be in the dark blue upper triangle. They are not. Some of them have lower coverage in healthcare workers compared to the total population. And that's where we really need to work on a switch in mindset and delivery strategies. Next slide. Here is a global map. Thanks again to all the data that we get. This is from end of August, so it may be a little bit outdated, but this is the percent we can see in the reporting member states on healthcare worker coverage. Next slide. As I said, 75% totally have been vaccinated of the estimated healthcare workers. Next slide. Oh, sorry. Sorry, can you go back again? I'm just wanting to show you the elderly map. There you are. And here you see an even worse painting than we saw with the healthcare workers. The elderly, the one that really needs these vaccines, have not been prioritized in the light blue triangle countries on the bottom because they have lower coverage than the total population. So there it really needs a mind shift. How to go, as previous speaker were talking, door to door, finding them and making services available in a more practical way for elderly populations. And also have the community engagement needed to be able to convince and discuss with the elders about the advantage of them having being vaccinated. Next slide. And this is just a map of the elderly populations and the reporting countries. Next slide. Let me now switch to the booster doses. So we know the primary series is not enough. We need to do the booster doses. We also need the additional booster doses, the fourth dose, in highest risk populations. And here you see the policy decision in 178 countries have led to a policy of booster and additional doses, but they are still lacking in low-income countries. 10 low-income countries have not yet started booster additional doses, and 10 countries across the Afro region. Next slide. And even if there is a decision on the policy of boosters, which is really important, the coverage is very low still. So the majority of the AMC countries have coverage of the booster doses below 10%. Here you see the red lines are the coverage of the primary series, and most of them are lagging very much behind in the coverage of the booster doses, apart from those on the left, which have more than 10%. Next slide. So COVID Delivery Partnership is partners between Gavi, WHO, UNICEF, World Bank, Africa CDC. We're trying to, as you know, have a concerted support together with the governments leading in seeing the 34 countries that were below 10% mid-January. And so all of us together, and particularly the countries themselves, have made extraordinary efforts. And here you can see in light blue, the population coverage increase since mid-January. In the majority of these countries, they have passed the 10%, and now there's only 10 countries left on the right-hand side. You see the green spots here. Those are the countries that also struggle with humanitarian emergencies, complex humanitarian situations. And in countries, some of you here, CAR, Chad, Afghanistan, not here, there has been extraordinary advancement, South Sudan, despite these humanitarian situations in countries. In some of the countries in Yemen, Haiti, and PNG as well, there is very much complexity and insecurity situations that makes really difficulty to administer COVID-19 vaccines. Next slide. So with partners, COVID Delivery Partnership are trying to really make a good mix here, include all the humanitarian actors around the table, around the government mechanism on COVID-19 vaccine delivery, trying to identify those populations, migrants, what are the coverage data, where are they, who are they not, are they excluded, and really put them into the micro planning of the one plan, the micro planning activities. We want UNHCR, IOM, MSF, and all the other actors that are actually on the ground as well to be able to support the governments to reach those latest miles if it is difficult for countries to do that. So this is what we're working very much from. Yes, 2 minutes more. Yeah. And next slide. So let me now, we can just a summary slide that you can have a look at later. This is some of the things that COVID Delivery Partnership are working with, the political advocacy, the funding, and the TA and public goods that we're developing, but you can have a look at that slide later. I do want to come to the last section, next slide, which is about the decrease in coverage globally. This is really, really serious. The partners around IA 2030, the global immunization strategy, are really doubling down now, trying to understand what can be done to mitigate and support the governments. And you are already, I know, thinking a lot about this, and a lot of efforts have been ongoing. The increased number of zero-dose children from 13 to 18 the last 2 years is staggering. Next slide. And all regions are affected, and Afro as well, 4% decrease compared to other regions as well. Here you see the light blue in the Africa region. Next slide. And you can skip that one and go directly to the integrated services. There are many examples right now of how countries are mainstreaming COVID. We know it's going to stay with us for a long time. We know we need sustainable immunization programs, inclusive of COVID vaccines, right? And sooner or later, we're going to have to stop with the mass vaccination campaigns and make something more sustainable. Have the booster doses work within routine immunization, giving services to elderly and the most vulnerable. And here are some examples of where they have succeeded in actually combining this together. Next slide. So I just wanted to show you one integration guidance that we recently developed with really concrete steps and assessments and tools that you can do to think about what is it that you need to be able to integrate COVID-19? What are the HR needs? What is the cold chain requirement that you need, etc. So that could be a help when you're thinking through this in your EPI programs. Next slide. And finally, the decrease in routine immunization coverage is really a worry. Some countries have managed through the pandemic. Many countries have not managed and decreased quite a lot. And it is time right now when there is attention, there's funding, a lot of willingness for the COVID-19 vaccination to use those same resources and build the stronger systems at the same time. The digital systems, the cold chain requirement, the investment in the HR that is needed, not just now, but for beyond as well. And as Iraq, Ethiopia, and Malawi are countries that while they distribute the COVID-19 vaccination, they also check out in the villages and number the zero-dose children that are not reached to bring them back to the system later on, to make a joint integrated campaigns, which is also so very important. Next slide and the last one. I just want to say again, pandemic is not over. The vaccination is really essential part of ending this pandemic, and we need to be dedicated the focus particularly on the high-risk groups, the introduction of the booster.
Not possible. As you can hear, I'm in an international Africa CDC WHO vaccination meeting double. So I can't stay. Yeah, so but
investments in the health systems and then advocate for the integration of the COVID-19 vaccine in sustainable programs. Thank you very much.
Thank you very much. I think for those that, please, can you just off your mic? If the mic is still open there, please, so that there's no interference. Thank you, Dr. Ann, for a brilliant presentation. So we're going to move to the next presentation by Dr. Mosoka on the continental perspectives. Dr. Mosoka.
Thank you very much, Dr. Nikis. In the next few minutes, I will try my best to give us a continental overview of COVID-19, starting with the EPI trends, vaccine coverage, the impact of COVID on routine immunization, what we as EU and Africa CDC are doing with respect to the vaccine program. Basically, on the slide above, you see the EPI data for the last 2 years. And basically, if you pronouncedly, you have 4 major peaks that have happened across the continent. Initially, there is a progression in the peaks. The last being the Omicron, and we all know what happened with the increased infectivity and how the implication. The minister spoke from South Africa with restriction. We've seen some minor peaks happening now. But what this has led to overall is that we have had 12 million cases on the continent. We have had 256,000 deaths with a case fatality rate of 2.1%. Well, I don't know if it's a good news or it's linked to some apathy. We will have about 11.4 million recovery. In one way, it is a good news, but on the other hand, I was in Algeria when I was told that, but you know, it's a challenge for us to sell vaccine because of the increasing, we don't see an increasing incidence of death and severe diseases. So it's a blessing in disguise for us, but we know for sure that vaccine indeed save life, protect from severe cases. If you look at the situation across the continent, the good news is that the pictures are not as bleak as they were some years ago. We have around 36 countries in the gray, all across, spread across from West Africa all the way to Central Africa that have 1 to 100,000 cases. 14 of the countries in the brown, the left brown, you see they're having 100,000 to 400,000 cases concentrated, some of them in North Africa, parts of West Africa and Southern Africa, with 2 countries having 500 to 1 million cases, all of which are in North Africa, Libya and Egypt. We now have 3 countries, 2 in Northern Africa and 1 in Southern Africa with 1 million or more cases. So basically there is a variation in the rate of spread of the disease, but yet the continent remains at risk. A couple of studies were conducted. The recent one, largest one being what they call the gender lab studies at Harvard. They look at 30 million persons. And then there's this pronounced study from Africa that look at the Afro region, setting up criteria, and the jury is all out there. There are 2 in terms of case fatality, in terms of mortality, gender matters and age matters. Basically, the male are more predisposed to having severe cases and death from COVID, and also the elderly between the ages of 40 and to 64. Some studies, conservative studies, around 70 to 80%. So basically, it reinforces some of the earlier presentation that spoke about targeting 100% of the elderly. And probably a very enlightening study is a situation from Southern Africa that plotted the life expectancy for people in Southern Africa over a long period of time. And what you see happening in the data is that COVID tried to reverse all of the gains and reduce the life expectancy. So you see this big dip between the onset of COVID-19 and the elderly population. Well, all of us will know we'll grow old one day, we want to live longer. Well, indeed, we see this happening. But the good news from here is that when South Africa decided to use the data, the evidences from the data, and prioritize and segment vaccination, especially for the elderly, you see that the gains have been, the losses have been reversed. So basically, we can conclusively say from this evidence that indeed, despite the fact that there is increasing vulnerability and risks based on sex, based on age, those can be reversed with a comprehensive vaccination program that is targeted. And so it sort of reinforces the fact that we're pushing for this 100% vaccination of the elderly, healthcare worker, the most vulnerable groups. So that's what we stand when it comes to the EPI trend on the continent. We know that there are increasing cases that are spread across the continent, and we do know the answer is vaccination. Where do we stand as a continent when it comes to the vaccine coverage? We stay at the continent with the most vulnerable population in terms of the fact that we still have 22.1% of our population vaccine coverage, with only 3 countries achieving the 70%. That is, and 2 of them uniquely located island country, which of course we know from malaria elimination, and Rwanda. The good news is there have been progress. We have 9 countries that have around 40 to 69%. We have most of the countries in 39%. If you look at the jury months ago, there were many countries that were less than 10%. When we started the initial discussion on the vaccine delivery partnership, most of the countries that had less than 10% were on the African continent, but we see that this condition is reversing. We are cautiously optimistic, but we stay far away from achieving the 70%, as only 3 countries have reached that very steep climb. So within Africa CDC, last Monday, we try to, every 2 times that we look at we run an emergency operations center and look at the data. So if you look at across the country, we've seen that over the last couple of weeks, around 25% of our country have seen an acceleration because of our many other interventions. There has been acceleration running from Benin, Burundi to Somalia. There has been acceleration. But some countries have sort of become very reluctant to push for, they are very complacent. We see that happening in often African countries, West Africa, all across the continent. There is a steady. And so in the event of a new variant, we know that every gain made can be reversed. Worryingly for us is that there are countries that are going down. You can see this, the vaccination coverage continuing to go down with respect to time, which for us is a serious issue. And we've been trying to brainstorm how we can help this country to effectively increase their vaccination coverage. So basically, we can conclude that Africa, we still have the risks, is real and present danger, but our vaccine coverage, while optimistic, is not very great. The goal of reaching 70% by December is a Herculean task, and we need to work together as a continent and member state partners to come together to achieve the goal. So what is also worrisome is that either the indirect effect of COVID, the misinformation, or our inability to concentrate all of our resources to battle COVID has had some unintended consequences, one of which is an negative impact on routine immunization. If you look at the lands that represent different regions of Africa, the effect has been a little bit less in Northern and Western, but the rest of the country we're seeing a big dip. So basically, if you watch over the years, all of the gains that we've made in routine immunization, we are beginning to lose those gains very rapidly. Even if you look at below the lines that show over the years, the increase in the number of unimmunized children is increasing. And 10 of those 10 countries are accounting for most of the numbers. So I was thinking on the slide, so the only word that came to me is that if we are not careful, we are going to win the battle against COVID-19, but lost the war against immunization. That's what I kept on thinking on. And we know if we lose the war against immunization, we have attacked one of the greatest public health interventions. We are alive. Many of us are sitting here and alive today as adults without disability because we have developed immunization. So we cannot afford to lose that war. We must try to use the momentum of COVID-19 to restore and rebuild routine immunization. So basically, we do know for sure that we have a double threat, double challenges, if I may say. One, we must work assiduously to achieve the 70% vaccine coverage in the midst of indifference towards vaccines, decreasing demand. Now we have the other threat that routine immunization is being compromised. So all of us here have a double task to achieve, to be able to restore lives and livelihood to our people, but at the same time, ensure we never lose the war against routine immunization. Now, what are we doing African Union, Africa CDC with the vaccine program? So there's a history. We do know where we started from in 2020 when things were against us. There were limited vaccines on the continent. I was then the Public Health Institute director. I remember trying to work with the military to go on the base to get logistics from Africa CDC when there was no logistics, no testing, and I couldn't sleep at night from March 15. And I know what it meant, the stress we had to go through. There were limited vaccines, airline has slowed down, but Africa CDC decided that they will create initiative from 2020 to help the continent in the issue of regional health security. One of those being the Harvard program, the Africa Vaccine Acquisition Task Force, was created for the very purpose of trying to find alternatives or to complement the COVAX platform. At the time, we do know, and I wrote an article on the challenges COVAX were facing at the time with the US government not being part of the COVAX, and I wrote some couple of articles. It was a challenge for us as a continent. Then we progressed to 2021. Africa CDC got the footing on the ground through the Abbott mechanism, giving country an alternative to acquire vaccines. We came to the first ministerial meeting, the partnership for vaccine manufacturing side to come. There was funding, I remember Dr. John saying that there was funds in our hands, but we couldn't get diagnostics. We couldn't get vaccine as a continent, as countries were looking deeply inward than to Africa. But we've made some steady progress. The SLF program was initiated, and we've now moved steadily to the second ministerial conference to take all our regional security, to work with member states to be able to fundamentally accept the reality that when it comes to health security, it has to be the region, the people themselves have to want it. And I think we made some substantial progress in this direction. How have we made some progress? We do know today that COVAX mechanisms remain the primary means of distributing vaccines across the continent, with most of them coming to Africa, but we are proud to say, as an organization entity, we've contributed to 8.7% through the Harvard mechanism that was created for the continent health security. Of course, those vaccine supply, we had the supply in, now is the demand side. We see, if we look at the continent, while it is true that we still have many countries have started to use the vaccine and require, but it's sad to know that if you look at the gray, we still have countries that have 25% of the vaccine unutilized. There are countries where vaccine has expired. And so this is saddening to note that the threat remains rare and alive. We cannot continue at this rate. We need to be able to vaccinate our population. And so it's good that we've gathered together today to see how we can build a momentum, restore the momentum in our people to reach the coverage. Because one of my colleagues was saying with me in DRC, if we don't seize the opportunity and to get our people vaccinated with the donated vaccines, if there were a variant tomorrow, it will be difficult for Africa. We must find ourselves in a being. So the SLN initiative, as our director spoke, Dr. Ahmed, is a momentum, transformative, respectful partnership where Africa CDC have been entrusted with 1.5 billion. But I like the way one of my bosses can say, the challenge we have is that we have to provide vaccines for 900 million people. This is going to be one of the biggest historic public intervention by any organization. We are trusted. And every day we get up in the morning and we travel across the continent. The reason that keeps us going is that we as African, as an African, we must succeed. There's no we can afford to fail. We have to succeed for our continent. There are 4 strategic pillars. One is to procure the vaccine, which has been working through different mechanisms. But the second is that, I like what my boss, Dr. Mohammed, will say, all vaccines on the continent belong to Africa CDC. So whatever means a country gets a vaccine, whether it is through COVAX, bilateral, or Harvard, our duty is to ensure that country distribute those vaccines and get them in the arms of people. Our third pillar is to be able to learn a lesson from the outbreak where we can manufacture vaccines so that we don't have to be vulnerable as a people and as a continent. Finally, strengthening Africa CDC. But I would like to zero in on pillar 2. What do? We help countries in procurement. We help them with logistics services, and we also try to monitor and help them to optimize the vaccine uptake across the continent. How do we do it? In the framework of the new public health order, 90% of all the implementing partners, we work through implementing partners. It's good to know that 90% of these implementing partners are African in the implementing partner because of the foresight of our leaders that tomorrow, if there is a matter of when the next outbreak comes, we'll have strengthened African implementing partner, non-NGOs and university to be able to take the road and run forward for the next outbreak. So basically, strategically, we work through implementing partners from end to end through all of our 8 thematic areas, from procurement of vaccines to last mile delivery to pharmacovigilance. I was giving a talk a few days at the university and said there are some bystander effect of the SLA initiative. One of them supporting the sequencing, two setting up implementation research, building the infrastructure for safety surveillance are going to be the bystander effect of the SLA program. It is sad to know that in sub-Saharan Africa, there are only 2 countries that have reached WHO benchmark of 3. But some of the bystander effect of the SLA initiative, not only delivering vaccines, but to strengthen the health system. What have we done so far? Of the 55 member states, our team have worked very assiduously. We've engaged 49 of the member states. I would say 50 because we have begun engagement with Algeria. We have developed country support plan. It's a bottom-up mechanism that we agree with countries to develop their priorities. Of those countries, we're happy to say just last week, we completed Chad and Ghana, making it 37 countries with macro plans. Of those macro plans, 22 of them have been approved. We have begun implementation in 6 of those countries. So we shifted from an urgent support mechanism where we're trying to avert that we are going now into a long-term support to countries across the continent to ensure that we help countries accelerate this ambitious goal of 70%. What have we done so far as a program? We have set up organizational structure. We've worked with countries, we've built infrastructure. Most importantly, we have averted 3.3 million doses from being expired. We've done it at a rate of $2 per vaccine dose. We have used our African implementing partner to build for the next wave of outbreak that will happen anytime in the future. We are in 49 of the 55 member states. Like I said, we've completed macro plan and we're now shifting to implementation. In the next couple of slides, we'll just show you that we started our implementation for all support in Ethiopia, getting with the local government member state and the ministries of health. We've done similar thing in Nigeria. We're happy to say that Africa CDC was able to provide the training for all of the 36+1 states. And now we are in 11 of they have given us 11 of the 36 states to do direct implementation. We're also in Kigali, Rwanda, to help them to accelerate going beyond just the 70% to children. We were involved in launch activities in Rwanda. So overall, since we began from the audience support to all support, we've been able to acquire some critical technical lessons that we are willing to share. Stakeholder relationship management was everything is critical. Working with our partner, community engagement, like when our colleagues said, we have revised the model from a static site to a mobile site, and we're pushing that. Branding and visibility was critical. Monitoring and evaluation, we must set targets. I've been working in many countries that have set targets. I've seen them succeed very well. Once the targets are there, because you can monitor, you can shift, you can self-correct when they are targets. We're developing operational manuals, we are developing lesson learned. In conclusion, we know as a continent of 1.3 billion people, we've been challenged with COVID, we've seen the inequity, but now we see that we have vaccines. We see that we are challenged with 2 critical things: achieving the 70%, at the same time, ensuring that our routine immunization is not disrupted. We've seen that we've worked hard to build supply chain system to help countries. What are the take-home messages we have? Today, the transmission is lower, but we cannot lose our guard. Let us take this opportunity, since our system is not stretched beyond measure like earlier times, to ensure we accelerate the vaccine uptake, one, but at the same time, ensure that we strengthen routine immunization. We have 100 days to achieve 70%. It's a tall order, it's an ambitious order, but shoot for the star and at least land on the moon. We have to achieve 70% target. We must be able to be targeted and segmented in our approach for healthcare workers, the elderly. And of course, some countries are now backsliding. We must ensure that routine immunization remains the same. If we can be alive because of immunization, we owe it to our children and the ones unborn to ensure that we build a strong routine immunization program. We must continue to restore trust in vaccination. People must believe in vaccines and trust. There's a saying we used to say in Ebola, the message and the messenger. We must find trusted messengers to take the message to the people to rebuild the trust. With partners in the member state, we must all ensure that it centers around the political leadership. We clearly have seen countries where there is strong political leadership, it leads to infrastructure. And once an infrastructure is built, it's easy to accelerate the vaccine. This is what we stand as a continent. We'll be very committed to member states to help us to achieve our goal to reach 70% in the 100 days, and at the same time, ensuring that routine immunization remains strong, strengthened, and powerful. Thank you very much.
Thanks, Dr. Mosoka. Thank you. So we're going to take a third presentation, which is actually slated under the session 2, if you have the agenda. So just to align with those the two previous presentations, and that's going to be with Dr. Fiona Atuebwe on the Continental observation on bottlenecks to COVID-19 vaccine rollout. Dr. Fiona?
Thank you very much, Nikesh. Good afternoon, everybody. I'm Fiona Atuebwe, and I'm leading the work on COVID-19 vaccination based in WHO Region Office for Africa in Brazzaville, Congo. Next slide. So I'll talk about this in 3 major themes: the governance plan, the bottlenecks we have observed in the governance planning and financing, on the demand service delivery side and the supply chain, and then the data systems and monitoring. This is information we've gathered from, triangulated from several sources, the observations we've had in countries, the interaction reviews, the visits we've made to countries as we support them, and lots of information from the several meetings and interactions we've had with the member states. Next slide. So generally on bottlenecks, we have 2 major issues. One is the demand. Just like type 1 diabetes, starvation in the midst of plenty. We have a lot of vaccine. There's a need. We know that there is need for this vaccine, but the demand for the vaccine has really, really gone down because of the drastic decline in the risk perception that followed the relaxation of other public health measures, and of course, the epidemiology of the disease, as Mosoka has shown on the continent. The other biggest bottleneck that we see to this vaccination is the competing public health priorities on the continent. We are still a continent that has a burden on other vaccine-preventable diseases. We've seen, and in other presentations, we shall see the big impact that COVID-19 has had on the overall health system that has led to emergence of outbreaks again. And of course, the political and economic priorities, we have lots of elections going on in the various countries, and all these have put a pressure on the vaccination. Next slide. So going to governance, in particular planning and financing, we have several bottlenecks, but I'm just highlighting the main ones that we've seen across board. We've seen countries where we had insufficient political will, and these are the countries that that we've seen generally have had a low coverage over time. We know we saw leaders that stood out and right from the start said no to the vaccination, not just government leaders, but also religious leaders, traditional leaders, and we know how the African culture works. If somebody in a key opinion leader gives a statement, it takes such a long time to reverse that. The other issue we've seen is the low level of transparency on available financing, of available funding in the countries. You know that in the different member states, we had partners or donors come in and say, we have $10 million or $30 million to support you. But then we do not know. Every time as we try to have the one budget under the partnership, that this one plan, one budget and one team, we had very major difficulties in knowing what financing is actually available. We know there's a lot of financing in countries, including domestic financing, but has been difficult for us to tell. Then, of course, this is a vaccine that came in a unique manner because of the low number of doses we had, plus also the stage recommendations and framework. We started with and still are on the highest risk priority groups. But of course, then we had the 10%, we had the 40% target, we had the 70% target, but also we know countries have your own targets. And these shifting targets also led to inadequate planning. Then the other major problem we've seen is the inadequate operational budgets, the ability for countries to cost and plan both at micro level and at macro level to be able to determine gaps. Resource mobilization is very difficult to conduct if we do not know the gaps, but across board in most countries, the resource gaps have been difficult to determine. Then we also had lots of countries being aware that there's a lot of funding from different partners, but the funding getting into the country is a big problem. But even when it is within the country, accessing the funding becomes a problem. The work happens at the grassroots, not at the national level. When the funding is even still with the Ministry of Finance, moving it to the Ministry of Health or to the sub-national levels, that disbursement has taken quite some bit of time. Next slide. When it came to governance, again, in the governance and leadership, we have seen what can happen in the kitchen when too many cooks get into the kitchen. Several partners came into the same countries and were doing the same thing. But because of and this also stemmed from the weak governance structures, even in the country where COVID-19 vaccination, unlike other vaccines in some countries, was taken under political leadership, under State House or under some major leader in the country that is not EPI, that is not an immunization leader. And that partner coordination also became a problem. Several partners in the same country and the coordination of these partners difficult. Now, the coordination at national level is a problem, but when it came to the sub-national levels in particular, it also became very difficult when partners went directly to the sub-national level, and that coordination was not well managed. Then we've heard that we had the national deployment plans, very excellent documents. We did the first phase at the beginning of 2021. Mid-year, we updated these. At the end of last year, when we got more doses, even updated them. Excellent documents were written, but the use of these documents for implementation has been a problem. There's the reality and there is the ideal, which is in the document. Data review, in most cases, when we had the pandemic, for example, countries continuously on a daily basis, we had the dashboards that showed the numbers of cases. And this number of cases and hospitalizations and deaths informed the decisions in the countries. They informed the lockdowns, they informed the relaxation of measures. But for this vaccine in particular, the data reviews, the review of data on a regular basis, and more so for use in decision-making, has not happened in most of the member states. We know that interaction reviews have been conducted in a number of countries, but for countries that have not conducted interaction reviews, interaction reviews have been seen to be a source of progress and changing and improvement, development of improvement plans, learning where we came from and where we are going. Unlike other vaccines, where by now 6 months into the vaccination last year would have started the post-introduction evaluations, we went for the interaction reviews. But even when for the countries that did excellent interaction reviews, big rooms like this full of people, highly funded, resource-intensive activities, the recommendations that were set were never implemented. Then the sub-national microplans to reach the highest priority groups still remain a problem. We've seen that in many countries, microplans for other vaccines are nicely done and implemented. But when it came to COVID-19 vaccination, it became a problem. Next slide. So under the demand, service delivery and supply chain, we've had a lot of bottlenecks that were identified. Again, these are a few. At the beginning, we had erratic supplies. That one everyone knows, until we had stability towards the end of the third quarter of last year, when we had enough vaccines. But we have countries that have the multiple products. We have countries on our own continent that have 7 products in the country, and that is quite difficult to handle. And of course, we know what happened with the short shelf lives that led to lots of expiries. Then we also have adequate cold chain capacity at national levels and probably at regional levels, but at the service delivery level, we are still finding problems with cold chain. But also the fact that the ultra cold chain was found at national levels, we've had issues at the sub-national level, having to use the vaccine in particular centers which are generally urban and not the rural for the ultra cold chain capacity problems. We are seeing a lot of vaccine expiries. So far, we have about 20 million expired doses of Continental right now as we speak. And most of these doses are still not yet destroyed, still within the cold chain, unfortunately. Even with clear SOPs on vaccine destruction and management of vaccine waste, COVID-19 vaccines, expired ones are still within the cold chain. And that's one major bottleneck because it reduces the confidence of the population in the vaccine if they are aware that this vaccine is still in the cold chain. So we do encourage the destruction of this vaccine. This presentation is strictly bottleneck. So there's another presentation that will be made by another partner on how to manage this. Engagement of communities. We had some countries that did an excellent job in engagement, but some we have seen inadequate and inconsistent. You go in once and come out and that's it. In polio, we know you go in and you have people who will say no to the vaccine, but you get back for a mop-up and get back to these people who did not take the vaccine, talk to them. This has not happened generally with COVID-19 vaccination. The social listening and analyzing what is happening, especially in the era of social media now, and tailoring our messaging, not the usual the same. People are tired of COVID-19 vaccination works. It will save you from severe disease and hospitalization. Everyone by now knows that, but there is a lot of misinformation that is online, that is also going around in communities that we need to listen to and message accordingly. Then the healthcare worker mistrust in the vaccine. These are the people who vaccinate. If healthcare workers are not trusting the vaccine and there's hesitancy among them, it's the correlation between healthcare worker vaccination and the total coverage in countries is very clear. Healthcare workers who are not vaccinated will not vaccinate. And this is something that we've seen in many countries. Next slide. So we had the previous speakers and also the opening remarks that we need mobile services. Fixed sites have not really worked for COVID-19 vaccination, getting to where the people are, but we do not have sufficient teams. Even in campaigns, we've seen inadequate teams and service delivery points for COVID-19 vaccination. Unlike polio, one country will have a polio campaign, a measles campaign, excellently planned for and implemented high coverage levels. But the same country will go out to do a COVID-19 vaccination campaign and come out with 2% coverage. And we do not understand what happens, but it's all because of the poor planning and before the implementation. Many countries do not have the readiness assessments, a readiness assessment checklist before they institute the campaigns, and WHO at the African regional level. We are now rolling out, we said better late than never, a clear checklist before any COVID-19 vaccination campaign can be conducted. Then again, we've seen non-payment and delayed payment of healthcare workers. If you do not pay that, because these same healthcare workers are the ones who do the polio campaigns, the meningitis or yellow fever, the lack of payment of the previous campaigns has really affected the campaigns, the same healthcare workers conducting the COVID-19 vaccination campaign. We've heard that now the new roadmap has changed and is focused more towards reaching the highest priority groups, 100% coverage in the highest priority groups. And this is because of the changing dynamics of the pandemic now, as we run towards the 70% to focus on the highest priority groups. Now, strategies to reach these target populations have not yet really been identified or implemented in most countries. Where do we find the elderly? Where do we find the healthcare workers or people with comorbidities? Non-communicable disease clinics, in the cancer institutes, in non-traditional places where we need to vaccinate and ensure we have vaccines, where we find the adults. Then challenges in identifying the high-risk populations. We know it's written on paper. Even in your NDVPs, you have the target populations. We know the elderly from the census. We know the elderly from the UN population. We do not know where to find these people. So that we've seen cross-cutting challenges in identifying of these high-risk priority groups. Healthcare workers are everywhere, but they are still not vaccinated. So some of those challenges, and we believe in the discussions that will take place now in this meeting, by the end, countries will have identified how do we actually go ahead and get to these people. Then, of course, we talked of the competing health priorities and showed the humanitarian crisis, countries with humanitarian crisis. Next slide. So finally, I will talk about the data systems. Next slide, please. Issues with the data systems and monitoring. So the poor data quality. This ranges from the completeness of the data, writing names with no ages, with no profession. So we don't know, is this an elderly person? Was it someone with comorbidities? So the data completeness, the disaggregation of data by the details that we need, the validity of the data, a system in place in countries to validate the data that has come from the service delivery points. And of course, the estimation of denominators is still a problem in most countries. We use the UN population data. Some will use the district level data. Some will use the census. Some will do head counts. What is the real denominator of people with comorbidities in the country, especially in a continent like Africa, where we don't know who has comorbidities and who does not? Then we have a lot of data backlog. It has been talked about in campaigns, use of paper-based data records, and then failure to transfer that on time. So there's delayed transmission of this information. Then suddenly we get the backlog entered over a period of a week, but this backlog is for 3 months. And then you see a country bump up in its coverage. Yet this was just a data backlog, not that they have recently done a campaign. Then the use of data for operational planning. So we have the data that has been entered, but there has not been sufficient analysis of data to make final conclusions from it and then do recommendations that can be used for operational planning and action. And then we did at AFRO an assessment, a quick assessment in countries, in our member states on the data systems that are being used and available in countries. So we found that there's a lack of electronic data collection tools, especially at service delivery level. There are issues with internet. When you look to the right, these are countries, just a sample of countries and percentage of vaccination sites that are using the electronic system. On top, you'll see Burundi, electronic system to record COVID-19 vaccination. But Burundi, we know, has the lowest vaccination coverage. But the good thing is that all their data is in an electronic system. So that's why it would show 100%. But a country like Malawi or Burkina Faso, Zambia, doing very well, and Kenya when it comes to data electronic systems. But we still have countries that are still paper-based. Their data is not yet in an electronic system. And again, we are seeing a lot of under-reporting on adverse events following immunization, while still lack of investigation of cases, of these AFI reported cases, and more so during immunization campaigns. We know how much loss of confidence this can be. At the end of every case investigation, we are supposed to have a report and either do a causality or not. Next slide. So finally, as we conclude, we saw recurring themes. We've seen recurring themes across countries on the bottlenecks, but because of the different contexts and the uniqueness in several countries, we've seen also peculiar issues in some countries because of different contexts. There are systemic challenges that are affecting the healthcare delivery system, and some of these are not just specific to COVID-19 vaccination. The demotivation of healthcare workers, the fatigue of healthcare workers, it's not specific to COVID-19 vaccination or the delays of disbursement of funds. It may be a general system problem that is affecting COVID-19 vaccination, but there are systemic challenges. Then, as we've mentioned, right now, focus highest risk priority groups, 100% in those groups as we move towards the 70%. So the lack of focus on strategies, and we've seen countries go for event-based where they're going to vaccinate football matches or youths and increase coverage just to get to 70%. But we know if we get another deadly variant now, we know the people who will be in hospital and who will die. If these are not covered and the youth are covered or primary schools are covered, we know who will still die, and we shall see those peaks in deaths, which is what we are trying to prevent. Otherwise, we have an opportunity to optimize the political commitment. We have here the member states, and the resources are now available. We have enough doses. We have enough funding on the continent. Lots of innovations have come into place. And of course, collaboration between partners for stronger and more resilient health systems. Thank you very much.
So we have really an excellent panel. At least the three speakers, they have done pretty well. So I'm going to ask probably to take a few questions so that we can really open the two presentation for discussion. So any question? Yes, Dr. Benito.
Thank you very much for this brilliant presentation. My name is Benito Impuma. I'm based at WHO Afro. I'm trying to put myself in the shoes of a given country where, let's say we have an issue in scaling up COVID-19 vaccine uptake. Maybe one of the things that from these three presentations, I think we need to make a distinction between what needs to be done by countries, what support can be provided by partners, WHO, Africa, CDC, UNICEF, and so on. One of the things that is clearly transpiring from these presentations are really in terms of like the operational capacity. I think it would be extremely important to know country by country, where do they stand as far as their operational capacity to scale up COVID-19 vaccine uptake is concerned. So that's something I think which we need to know, and then it can highlight the type of support that needs to be given. The other thing that may be required from Africa CDC, WHO, UNICEF, and so on, is the issue of targeting the high priority groups. In practice, I'm not talking about the what to do, but how to do it. So if you look at countries, I think in many of the countries, especially like the Francophone countries, they have what they call the CTA, the Centre de Traitement Ambulatoire, where you can easily find people living with HIV/AIDS who are being treated. So in practice, maybe the how in terms of vaccine is to liaise with those groups to ensure that they can be vaccinated. The other thing is healthcare workers. We know where they are, and we need to devise specific strategies to ensure that they get vaccinated. If you look at the body of literature, some of them in some countries are very reluctant to get vaccinated. And if you are a healthcare worker receiving people and you don't even believe in that, I think this is something we also need to consider. And then as far as diabetes is concerned, there are also specific clinics where you can find them. I think the difficult part is when we talk about those above 60 or 65, they are scattered in the population, and it can be very difficult to have a clear strategy to target them. So for me, this is something we may need maybe a step-by-step guidance on how to reach those high priority groups. The other thing which I think is also extremely important, I think it was mentioned there, is the issue of data system which keeps coming. I mean, it's be it at country level, at regional level, and so on. One of the things I've seen so far during the COVID-19 is a situation where even in countries or even within the institutions, you will have a bunch of data on the epidemiological situation, like we've seen here. This is where we stand, and it's sitting somewhere. On the COVID-19 vaccine, you have it sitting somewhere. And then even within the COVID-19 vaccine, you have like the safety data sitting here and there. So I think when we say we want to strengthen the data system, it's a huge task. And I think if you look at the ministries of health in general, there's very limited investment in data system strengthening. So if we really want to address that, I would say let's have some discussion to have dedicated actions to ensure that some of these data colleagues who are necessarily not public health experts or medical doctors can be brought on board from other ministries to strengthen this specific area of work. So for me, this is something I think we need to ensure that we have the right skill set to address this. And then lastly, I think on the analysis of the bottleneck, I would strongly suggest that we go to there's a report which was recently released analyzing the bottlenecks on COVID-19 vaccination in 14 countries. And this is really a detailed scientific analysis which was conducted with clear kind of action points that should be taken. I would strongly advise that we look at that paper, and I know it came from the International Treatment Preparation Coalition and People's Vaccine Alliance, and it's online, and it's worth really looking at it. And during our work group, group work, we can really review this. And then lastly, what I see from these three presentations, it's really I'll say 4 elements. One is like the need to scale up COVID-19 vaccine uptake. So the scale up idea. The second one is really the transition. How do we transition from like COVID-19 vaccine uptake to like the integration into the primary healthcare and so on? And then the third one will be the need to consolidate what we have learned. One of the things I've seen, I think it was a colleague from Africa CDC, there was a nice slide highlighting best practices or good practices. I think we need to find a way of, during the exchanges with our member states, to compile emerging best practices and then put them somewhere where they can have access to it. And then as they start implementing, they can learn from each other. And if we can come up with, I don't know if it should be a platform or a way of disseminating those good practices as we go, that will really help countries in what they will be doing. So let me stop here. Thank you, Nikes.
No, thanks so much. I think those, if I take it from the last point, that's exactly the plan. We should be actually sharing best practices across the different member states, those that are doing very well, those that are aspiring to do well, and those actually aim to. So we'll definitely do that. There's a provision for that, Dr. Benito. I do agree. The 3 points, I think those are comments, very good comments. They need assessment. We need to know what are the need for the member state, and then definitely they're going to tailor out the level of support that's going to be provided to those member states. The operational capacity, very clear. I think you're bringing another component, very good one, which we're all aware, around the priority groups. Very good. We'll keep that at the back of our discussions as well. And the data system, data. If you don't know your data, you don't know your epidemiology, you don't know. I think that's going to drive the way we really implement some of the new strategies that are going to emerge from this workshop. So thanks very much. Very good comments. Let me allow maybe 2 more comments, and then we can wrap up this session. Yes, please.
Thank you very much. I really appreciate Dr. Fiona's presentation. She is very right. We see that fixed site is not really working for the COVID-19 vaccinations. Depending, especially for some country, I'm from Sierra Leone or Nyandemo, I really play with the data for the COVID-19 vaccination in my country. We observed that last year up to December, we are using few teams and most of the fixed sites. But when we started implementing the search strategy, doing more of outreach and having more of mobile team support, with also Africa CDC supporting through Focus 1000 in Sierra Leone, we saw that we have a high vaccination rate. As of December, we are at 7.8%, but as of now, I'm talking to you, of the national population, we are at 25.8%. But again, you look again at our target. For us, our target is 12 years and above. For our target for 12 years and above, we are 39.1% fully vaccinated. So you observe that fixed site is not really working. Talking about the data is not really prioritized because as presently I'm talking to you, most of our data are not in the DHIS2. Most of the data are there lying down. We are only now collecting backlogs data, entering backlogs data. So you observe that we have even up to 1 million data that are not in the DHIS2. And the DHIS2 this is a platform where international partners have access to. For us, we only use our Google Drive at the national level, which we use to send our report based on what we call our CTREP to partners. But when partners are looking at it, they look directly what is the DHIS2. They don't look exactly at what we are giving them, even in our CTREP reports, even having our TWGs. So this is purely the problem. And Sierra Leone having a country, we have about 1,600 health facilities. You can't believe we don't even have up to 300 data devices. So you observe that most of the facilities don't have a facility level. The data devices are only at district level. And most of the vaccination are happening right at the facility level, which is the PHU levels. So I'm waiting for those forms to come to the facility, to the district, to be entered to the DHIS2. Most of them get missing on the way. And archiving is a big problem in Sierra Leone. So we really have to prioritize data. Thank you.
Good. No, thank you so much. I think I think there's a last comment, Ethiopia, before we wrap up the session. So we have a session dedicated to country, experience and so on. I just want to be sure that we don't open that now, because otherwise we're going to end up with all the member states in this room to share their own experience. But if there's a burning question, please, or comment, just allow us. We can take Ethiopia, please.
Okay. Thank you very much. This is Dr. Meseret Zelalem, the Director for Reproductive Maternal Neonatal Child Health and Adolescent Health, in fact, in nutrition at the Federal Ministry of Health. I'm really appreciating the organizing agent for this timely agenda. Perhaps my comment is when we present the continent as in general, it's good to understand the continent in a pretty different way, because we have really reached to this level by mitigating like a different, problems we were really facing. Perhaps the humanitarian condition, be it natural or, man-made, this is really, the continent is really facing, so that it's always good to zoom in. The continent is pretty different. And also, vaccinating an adult population versus the pediatrics population is pretty different, because the global experience here is, including Africa, is vaccinating pediatric age groups with having a great foundation in it for the last many decades. But COVID is a new incidence for all of us in the globe, so that this is a pretty new experience to vaccinate an adult. So it is not a simple science where we can really conclude with one statement. It's easy to, the routine immunization, but now in the same country, COVID is not as it's expected. So we have to really understand the system as a whole. So perhaps my ask will be for the developing partners, perhaps for the WHO regional office with other partners organization in addition. We have seen the challenge that you have presented. I appreciate the Fiona's presentation. So what are the mitigation strategy from the WHO regional office to leverage the member states to mitigate for all the challenges that you have already presented? And I'm really looking forward. This mitigation strategy will really help us a lot to strengthen our health system. It's not only for COVID, but for the next any emergency situation to be more resilient. So this is the comment that I have, and I'm really expecting also innovation. Thank you.
Thank you. So I would definitely, Fiona, there's a question addressed to you. I'm sure that you can take it. Yeah, the mitigation strategy. I just want to be sure we at least answer that question. Yeah.
So thank you very much. I just did not want to really preempt, because we have a big agenda and there's a session that is dedicated to mitigation strategies. All these bottlenecks, and then countries also identifying, I believe this afternoon, there's bottlenecks and the mitigation strategies, but there's a session, I think it's tomorrow, that was to be taken by Imran. That will be done by Florence, that we've all gone through and discussed, which is on the mitigation strategies, but also like Dr. Benito mentioned, there's a whole document that has been written on these bottlenecks and mitigation strategies. So there are lots of mitigation strategies that have been put in place, but I don't want to preempt the next speaker's presentation.
Excellent. I think that we're all co-creating this. We're going to be sure that we all gather these, I think, mitigation strategies in one single document that's going to be shared toward the end of this workshop. So there's that opening remarks that we missed this morning. I'm not sure if Amref is in the room. Not. I think, again, yes, please. This is going to be really brief, please. If you can take 2 minutes, that's going to be enough that we can conclude this session. This is Dr. Misrak Makone. Please, 2 minutes, if you can.
Thank you very much for the opportunity to reflect a bit. And actually, one of the points that I want to bring up also relates with, because I don't want to take you back to the agenda, but, you know, really taking into account Dr. Masarat's point in terms of really contextualizing the country needs in terms of, you know, what countries are dealing with are beyond just COVID, but other situations such as drought, war, and also other disease outbreaks. So that's actually one of the key points that I wanted to bring up earlier this morning. As AMREF, we want to actually thank you for participating in this meeting, and we've been engaged actually supporting other, over 24 African countries through the different pillars. And just to maybe highlight some of the lessons learned, because I know we mentioned it this morning a bit, is really supporting the technical assistance model. We talked about earlier on in terms of what is the role of country programs, what are the role of partners, what is the role of African CDC. And one of the lessons learned that we've had over the 18 months is really focusing and listening to ministries of health and really buying into the one country, one plan approach, because every country is very much different, and we really need to become a reliable partner into a country-owned and country-led model of delivery. So I think as AMREF, that was one of our key learnings through the last 18 months and engaging in the pandemic. The second one focuses on really being a savvy negotiator and a strategic advocate for vaccine equity with donors and global powers, because it's very important that African voices need to be part of the advocacy agenda, and we shape the African narrative. So that's something that we really want to emphasize as an African nonprofit. Thirdly, we talked about it a bit this morning. It's about the healthcare delivery, is really recognizing that our health systems really rely on a very well-organized health workforce. Again, we really need to be grateful of that structure that we have that gets us to the last mile, but most importantly is to motivate them and to retain them, and also to really think out of the box and try to become innovative in terms of really thinking outside of a vaccine delivery approach, where we engage other health cadres, for example, pharmacists, to be able to deliver, vaccines during emergency. So how do we really make that, task shifting that we did during the HIV pandemic, what is applicable now to the COVID-19 scenario? So those are the things that we really need to think about. And lastly is also really looking at who are our major clients, because I know we have major health systems with really issues around, logistics, etc. in terms of the delivery. At the end, our main clients are the community. So how much are we engaged into really understanding their needs and really designing the service delivery across our communities? So if they are the center of our work, how do we design it so that, be it, to increase the accessibility of it? So that could be around, mobile outreach, flexible timing and convenient spaces, because at the end of the day, we need to reach the communities, that is in a place where there's, convenience is as a major factor. So I think as we move forward, we have all these learnings, we have all of these experts. So how do we maximize on really tackling, thinking beyond the COVID-19 scenario, thinking about the integration we talked about earlier this morning, and and most importantly, really bringing the different partners into this equation to deliver a successful system that could create a more resilient one for our continent. Thank you very much.
Thank you. Thank you so much. So now I think this session will come to an end. So we'll have an hour. Senga, that's an hour, right? If you can come in for the housekeeping. We are an hour behind our schedule, so we need to find the best way to catch up here. Mm-hmm. Okay. Good. Let me invite colleagues we have a couple of announcements so that we don't miss our steps here. So Lillian, Dr. Landry, you want to come and provide those announcements?
Good afternoon. We welcome you again to this meeting. There were some housekeeping rules that we should have mentioned at the beginning, but we apologize, we did not. One of them is those who want to access the internet. There is the AU guest that is open. As long as you get into the campus, you can just log on to that one. It's open. Then we were told the French people are having a challenge. Please tune in to channel 2. That's where you'll get good translation. Someone lost a phone, a Techno PN5. So in case you come across it, please hand it to any of us. Please note that every morning we are going to go through the COVID testing. So to this note, we encourage that we wake up a little earlier and set out a little earlier. Today we had challenges, but we hope tomorrow we'll have ironed them out and we'll be able to get into the campus without much hassle. Your DSA. Please note that we have catered for your hotel accommodation. For those who are catered for by Africa CDC, we have paid bed and breakfast for you, so you should not pay anything to the hotel. We shall be paying you a DSA, which will meet your evening meals and any other extras. But the bed and breakfast is catered for. The airport pickup is also catered for within Ethiopia. We picked you from the airport and we'll take you back to the airport. That is catered for. We are a big group and we might not be able to pay out everyone today. We have 3 days and we propose today, depending on the time we return to the hotel, we will pay from when we return up to about 7 o'clock. So those who will be ready to receive their money can come over. For DSA, we will need your boarding passes, at least the pass that brought you into Addis. And then if you did a COVID test in your home country and you paid, please, you can also come with that receipt. If you paid for visa, please also carry that receipt. We are aware some people paid for visa twice because the system did not generate the visa form. So people were asked to pay again at the airport. We are aware of that, but you need to prove with receipt on email that you received after payment online and the physical receipt that you received at the airport. We know there was that anomaly and we are willing to cater for that. As you're aware, there is a strict protocol for this place, and we've been requested to inform you to always wear your masks when you're in here and sanitize. In case you have any problem, maybe you've gotten an allergic reaction or something, please let us know. We'll take you to the clinic and do some investigations. Like I mentioned, let's keep time because we're a big group. When we say we are moving back to the hotel, please let's all gather and move at once. Thank you very much. I'll be available for any questions. Thank you.
So thank you so much. Mine is pretty simple. I would like to introduce briefly what will happen after lunch. We are going to go into group work. My name is Landry Tsage. Just to introduce myself, I'm the Senior Health Advisor with UNICEF, the office to the AU. So all the delegates should have received before coming to Addis from the organizers a template for what is called a country-specific roadmap development. And you were requested before coming to Addis to discuss with your country team and to address the bottlenecks of COVID-19 vaccination at country level. We also requested you to focus on going a bit in depth into the root causes of the bottlenecks of COVID-19 vaccination. So what will happen during the group work of today is going to be about the conversation among member states within the same group. And they will focus on few thematic areas. We are not going to request you to discuss about all the 5 thematic areas that we have on the agenda. I'm sure you remember on the agenda, we have listed 5 thematic areas that will be at the center of our discussions. The first one being political leadership. The second one, demand. The third one, health workforce and delivery strategy. The fourth one, supply and cold chain systems. And the last one, operational costs for vaccination. So the methodology of the group work will not require that a member state or member state delegate discuss at the same time all the 5 topics. Time will not allow us to do that. So what we are going to present in the next few slides, so let me invite Senga to bring up just the allocation of countries by group and by teams. So let me first maybe thank all the facilitators from various organizations who managed to come to Addis in person to support this process of group discussion. As you know, it's going to be the most critical part of our gathering. We really want to make sure that the interaction within groups generates new ideas, adds value to what countries are currently implementing in terms of accelerating COVID-19 vaccination. So we have organized member states in 8 groups. And for the sake of ensuring fluid discussion, we grouped member states in 3 groups: French-speaking member states as working language, 4 groups of member states using English as working language, and a group of member states using either Spanish or Portuguese as working language. So on the screen, you have the first group, Group 1A. They will include Benin. Maybe I don't want to list. You have the names there. What we have done, we have printed the allocation of countries by groups and by team. So the facilitation team, we have access to the printing document. Izine is going to be ready by the time we leave this place. So what you can do at the moment is to take a screenshot of the screen when your country is listed. So at least you know where is going to be the venue of your group work. So Group 1A will meet here in this main hall, the Nelson Mandela Plenary Hall. We have also indicated who is going to be your lead facilitator and the co-lead. Next. The next group is going to focus on political leadership, health workforce, and delivery strategy, Group 1B. And this group will meet at Community Room 1, the old conference building. Please, members of this group, be aware that your venue is not in this specific compound. It's at a compound about 300 or 400 meters from here. So you will take a bus at the exit of this hall to get to that venue. But don't worry.